way to. But they need to that.
We did it. Your patience. Fun. All right. Thank you guys very much for coming down. We appreciate it.
Of course.
Yeah.
And thank you again. Yeah.
Okay, thanks for your patience. We're going to go ahead and get started. So let me introduce Dr. Kelly Farquharson. She is a professor in the School of Communication Science and Disorders and director of the Children's Literacy and Speech Sound Lab, class lab, as she's listed up there. Her work has a mission to help children with speech and language impairments achieve classroom success. She uses implementation science to guide many of her research questions with a specific focus on optimizing the workloads of school-based speech language pathologists. Her work has been funded by the National Institute for Deafness and Other Communication Disorders. And if you don't follow her on her Instagram, I hope you have it up there. So, okay, please do. She has a huge following, lots of great information. So if you can find her on Instagram, please do so. But thank you for being here, Dr. Farquharson.
Thank you, Dr. Dennis.
You're
Thank you
welcome.
for inviting me, and thank you to the official tech and the non-official tech team for helping get this set up. I'm excited to talk to you all about partnering with speech language pathologists in school-based settings. So I kind of approached building this through the lens of knowing a little bit about the audience here, which is mostly researchers or researchers in training and people who think about other people in school-based settings. And so there are some slides that are a little speechy heavy that I'll just say you can kind of ignore the speechiness of this to help focus just a little bit more on the idea of building partnerships really with school-based professionals. So as Lindsay mentioned, I'm in the School of Communication Science and Disorders here at FSU. And let's see. And right, there we go. My lab is Class Lab, and that's our website here. My email address is here. I have all this information at the end as well, if you'd like to keep in touch, including my Instagram, which is at @classlab_Kelly. And as Lindsay mentioned, the mission of my lab and the overall purpose of my research is to help children with speech and language impairments achieve classroom success. And over the years, I've really learned a lot of my original or kind of early work was focusing mostly on working directly with children, and we still do that. But over time, I really kind of learned a little bit more about the importance of partnerships with individuals who work with those kids. So even though a lot of our studies are still focusing on children who have speech and language impairments and how to ensure they acquire the language and literacy skills necessary to be successful, we've really pivoted a lot of our work to focusing on the people in schools who are truly responsible for helping to build and sustain those language and literacy skills. And for my work, that is really largely school-based speech language pathologists, but also of course includes classroom teachers and other professionals. My lab is filled with an incredible group of people who make all of this work happen. And so I can't for one second even remotely think about not thanking all the work that they do to really pull all of this together. And so I'm going to talk today a little bit about implementation science, which I think is probably a term you've heard or know a little bit about. And this is referring to the study of strategies and procedures that facilitate the use of evidence-based practices by practicing clinicians or policymakers. So it is really a way to kind of conceptualize the what works for who idea and under what context. And so the context that we're really talking about here is an elementary school or a school in general. But this idea of implementation science has been a really powerful game changer for me and helping to reconceptualize the kind of work that I want to do to help clinicians and to help children. And so, like Dr. Cabell, I was a member of our fellow for the Research Institute for Implementation Science and Education, or RISE program that was funded by IES and supported by the University of Washington, the Smart Center at the University of Washington. And so this was a 2-year training program that really provided a lot of the foundational information that I have used and implemented in my own research. And so for those of you who may be interested in learning a little bit more about implementation science, the Smart Center at the University of Washington has created some really incredible learning modules that are created to help support really beginning individuals who are wanting to know more about implementation science. And so there are probably more than 2 modules developed at this point. Do you know?
Probably.
Yeah. So there's 2 that were definitely created on implementation science overview and implementation strategies. And then I can send this link separately, but I would recommend if you just Google Smart Center, University of Washington, implementation science, you will definitely find this. The Smart Center is the name of the main research lab that oversees a lot of this work. And so then for my research and my research questions, why school-based settings? A lot of the implementation science research really originated in more healthcare or medically based settings. And so a lot of the early research on this topic was reflecting that particular origin. So really much more healthcare specific, thinking about insurance reimbursements, medical concerns, dosage from physicians and bedside evaluations and things that were really heavy in a more medically based setting. But school-based settings have similar needs to use implementation science to help us secure, contextualize, and examine the ways that evidence-based practices work for children and educators. And so I'm going to talk just briefly about some implementation science frameworks because there are dozens, and I don't really think it's a good use of our time to go over a bunch of them, but I will just kind of highlight a few if you're brand new to the idea of implementation science, just to get you started. And I'll spend a little bit more time on the first one, which is EPIS, exploration, preparation, implementation, and sustainability. This is the one that most of my work kind of lives within that framework, and specifically within the stages of implementation completion, which I'll talk more about. CFR is another common one that you can look into, Consolidated Framework for Implementation Research. And then the REAIM 2.0, which is reach, effectiveness, adoption, implementation, and maintenance. And so all of these are very common models of implementation science. So again, the idea of how do we understand what's happening in a particular context? How do we understand the extent to which, why, how certain evidence-based practices are used in that particular context? Or importantly for my research questions is like why they aren't used, not necessarily why they are, but why they aren't. And so I have some screenshots here just to orient you to some of the critical research that I see as foundational related to the use of implementation frameworks in research and practice. And so this article talks about 10 recommendations, which I have also screenshotted here. My work lives largely in the first 3, which is really this exploratory phase. And so we also call that pre-implementation, and I have my next slide will show you a little bit more about that. But this is really where my work is living, and a lot of the work in communication science and disorders or speech pathology is in this pre-implementation stage, because there's just a lot that we need to first explore and understand about these contexts, the context of public schools or settings in which speech pathologists work, before we can move into trying to figure out how we can implement a better practice. We actually have to understand maybe they're using a good practice already. So we have to kind of see what's happening in schools, what works for whom and why, before we can really move into the remainder of these specific implementation outcomes or other action items. And so this conceptual model of evidence-based practice for public school sectors has really informed, or public service sectors, has really informed a lot of my work. So this idea of having a 4-phase model of implementation. And again, we're kind of living mostly in that exploration stage of it, of EPIS. And so this is a very common visual of what the EPIS framework looks like. So you'll see kind of on the blue arrows around, this is visually overwhelming, I know, but the arrows going around, you have exploration, preparation, implementation, and sustainment. So that's EPIS or EPIS. And then there's just all different kinds of context to consider. And this is what makes this idea of implementation research really exciting for me, is thinking about all the different contexts. So those of you who've been in a school as an educator know that there's just so many moving parts. And if you have worked in more than one school, then you know that there are a variety of those factors that are drastically different from school to school. If you've worked in multiple schools across multiple states, like I have, you know that there's just drastic changes across state lines with respect to different legislation guidelines that educators are required to follow, SLPs in particular for special education. But also just the context of the school, the building principal can kind of drive the climate and that will change depending on the school that you're in. So there's just so many factors. And what I really like about this particular framework is it allows for examination of a variety of these factors. So you're not just looking at what's happening for kids. You're not just looking at what one teacher's doing. You're really considering the whole context. And that's been a really important part of our partnership with SLPs that we've been working with. And so I mentioned that we are mostly using the stages of implementation completion. This is kind of a, without going into like extreme detail about these implementation science models, this kind of lives within EPIS. So this is kind of a way to break down the exploration, preparation, implementation, sustainment EPIS model into additional stages. And as I mentioned, we're really focused on the pre-implementation stage, which includes engagement, consideration of feasibility, and readiness planning. So I thought what I would do today is just tell you a little bit about how the kinds of studies that we've done to work on engagement. And we're currently in the second stage, which is consideration of feasibility. And so I thought I would just tell you a little bit about some of the work that we've done and how we've structured these studies, particularly if those of you who are in doctoral training programs are interested in learning more about how you might be able to use implementation science or how you just kind of begin this idea of partnering with the people that you want to partner with, some examples of how we've done that. And so specific to school-based SLP, one of the reasons that this is exciting for my work is the frameworks of implementation science are tied to an assumption that there's a variety of evidence-based practices to implement. And in speech pathology, some of the populations we work with within our scope of practice, there is maybe one evidence-based practice or even less than one evidence-based practice to use to support the development of speech and language. And that might seem outlandish to say, but it's very true that we don't have a ton of empirical work to support the critical services that we provide. And that really leaves clinicians in a very difficult position with not knowing how to treat every kid on their caseload when there aren't evidence-based practices available to do so. And importantly, and where my work really lives is a lot of the evidence-based practices that are available have never been tested in school-based settings. So they've been tested in our ivory tower silos, and we know that they work in a perfect context in which kids come into the lab and they're seen in a quiet setting, one-on-one for 45 minutes, and they're able to make this progress because there's no barriers to their ability to do so in this kind of sterile and quiet and perfect environment. And you go into a school and it is anything but sterile and quiet and perfect, right? It is perfect, but it's not sterile and it's not quiet. And so we really do have to understand how do these evidence-based practices, if they're documented to be, if there's evidence to support that they are effective to help improve communication, do they work in a school-based setting? And a lot of the variables that I'm going to talk about include things like, as a speech pathologist, you might be pulling children out of a classroom into a smaller room, maybe a much smaller room, and providing services. Maybe it is one-on-one, but it is likely to be small group. We actually have no research studies. We've done just a teensy bit that I'll tell you about. There's very little research to support that small group services are beneficial for children. And there's very little to support that individual services are beneficial for children. So the ways in which we are actually providing these services, there's been no studies to help us understand, is this actually effective? Is there a better way we could go about doing this? And so that's kind of where our research started, is this idea of engagement. So engaging with our partners of interest, which are school-based speech pathologists, using surveys and focus group data. So I'll tell you just like a couple of snippets from this. We've done several different rounds of surveys trying to understand different things like how SLPs interpret the law, how COVID impacted the kinds of services that speech pathologists were providing, how SLPs are determining children to be eligible for services. Even though there's guidelines from the federal government, there's extreme variability with how that's actually implemented. How SLPs perceive the idea of collaboration, how the change in their job satisfaction was impacted by COVID. And so we have really done several different rounds of surveys to really try to fully understand the context in which SLPs are being asked to work and practice. And we're incredibly thankful. We get usually around anywhere between 500 to 1,200 SLPs responding to our surveys. And we've gotten such incredible information from them that has really helped to inform our ability to develop partnerships with them, because we feel like we're able to understand what they're going through and able to kind of talk about, okay, we understand from at least this small-ish sample, the kinds of things that you're up against. And so some examples of this are the variability between and with states regarding how children are determined to be eligible for services. So, it's a fine line whenever you're determining eligibility for special education, between having this rigorous, solid, an inflexible way that everyone follows for every single kid, meaning that the approach to data collection for assessment looks the same for everybody. And we don't necessarily think it has to look the same for everybody, but what happens is because it looks so different for everybody, the decisions that are made at the end of those evaluations are very different as well. So some children may be eligible for services in one state, they move state lines, they no longer are eligible for special education. So you either have a disability or you don't. It doesn't matter what state you live in. But currently, there's so much variability in how that's determined in schools that it does actually change whether or not you are documented as having a disability, depending on what state you live in. And I think we would all probably agree that that's just not an effective way to provide services. We've, in one survey, found that 37% of our sample, which was over 200 SLPs, indicated that they know there are children in their school who need SLP services, SLP, speech language pathology services, but they can't provide those services due to district guidelines. That's a huge problem. Obviously, there was a decline in job satisfaction during COVID-19 school closures with a lack of support. That was over 1,000 SLPs reporting on that. And then during that time also, we had we asked SLPs about the kind of support, resources, training they received to do teletherapy. They were asked to transition to teletherapy. Some people with like very little skill level related to even turning on a computer, let alone providing therapy online. Only 16% of SLPs surveyed, so that was 177 of that 1,000, indicated that they received any training whatsoever. They were asked to just kind of, like most of us, go home and good luck. And so, of course, there's going to be implications for what children's outcomes look like there. So then the other thing I want to talk about with respect to how we have engaged with SLPs is using data from the experience sampling method. And so I have a couple slides talking about what the experience sampling method is because I love this method of data collection. It's been a really interesting one to engage in, and we've learned a lot, and I think it's a really cool thing to collect kind of in situ or live data. So experience sampling method, or ESM, is a quasi-naturalistic data collection method used to investigate daily life as it's directly experienced. And so we kind of use this to compare against survey studies. We've done a lot of survey studies, so this is not in any way saying that surveys aren't valuable. We found them to be incredibly valuable. But a lot of the research behind the experience sampling method suggests that it is viewed to be a superior way to collect data because in lieu of asking someone to rely on their memories of an experience, you're asking them in the moment what they're currently experiencing. And so it kind of eliminates that bias towards more recent experiences or more intense experiences, and really kind of gives you an opportunity to like see what someone is experiencing in the very moment at the present time. And so the way that I think about this is experience sampling is like, hey, what are you doing right now? And surveys are like, hey, what were you doing a year ago? And how did you feel about that? Right? And so both are valuable, both can give us some really important information. But the experience sampling method has been really helpful in trying to figure out what's happening in this moment for clinicians. So what that looks like, and I'll just quickly go through this list. This is documented to be a really flexible approach to data collection that's ecologically valid. You get immediate information. It's minimally invasive, and it's comprised of short, direct, and self-report inquiries, which also relies less on the memory of participants. So it's really just kind of what's currently happening. And so the way that we have designed this is through, we use a phone app. I'm going to tell you the phone app that we use, although it is no longer operational, I'm sorry to say, but there are two new ones I'll tell you about. The way that we've designed our experience sampling studies is we have SLPs participate for 1 work week. And then through the app on their phone, they get up to 3 pings on their phone a day. So in the same way that you would get a text message, they get a ping 3 random times a day. We have them participate for 1 work week. So it's 5 days, up to 3 times a day. So they can get up to 15 text alerts or pings on their phone during the week of their participation. And it's a short, less than 1 minute survey. and they get paid per survey. So they get paid per survey response. So the text message will come up on their phone, or the ping from the app will come up on their phone, and it will ask a triggering question, a trigger question. So it will say, for our studies, for example, something like, in the past 30 minutes, did you provide therapy to a child with a speech sound disorder? So speech sound disorder is the main population I study. These are kids who struggle to produce speech sounds. And so I'm interested in what their therapy looks like in the school. So the question on their phone is, in the past 30 minutes, did you provide therapy to one of those kids? If they say yes, they see an additional 8 to 10 questions. If they say no, that's the end of their data collection for that moment. And they get paid regardless of whether or not they say yes or no, but they have to respond somehow to that ping. So they have 60 minutes to respond to the ping. If they don't respond at all, they don't get a payment. If they respond yes or no, they get a payment. And we pay $3 per response, so up to $45 for a week of participation. And we're currently running one of these studies right now. So that's the ping of like, hey, what are you doing right now? So the app that we used in our main speech sound therapy study was called Paco. Unfortunately, it is no longer operational. The next slide has 2 other app options, but I did want to just show you kind of what the screenshots look like. So over here was just like speech sound therapy dosage, time to participate. So it would come up as a ping on your phone, just in the same way of, that someone commented on your Instagram post or that you have an email. And so you just click on that, and then you would see, in the past 30 minutes, have you finished a therapy session? If they said yes, they would get a series of additional questions. And the goal here was to keep these questions less than 1 minute for them to participate, so that they can just say how many kids were in the therapy group, 2, how many other children were working on speech, 1, so that they can, as quickly as possible, and we pilot that to make sure that it's, roughly a minute or less that it takes for them to participate. So the 2 other apps that are currently available for this, and one we've used with the University of Wyoming, which is one of our partner institutions. Dr. Amy Peterson there has led this study. It's called Mind Sampler. Now, Mind Sampler connects to Qualtrics, and we do have Qualtrics here at FSU. So that may be one that you want to look into. It is expensive. So it does come with an annual price that you would have to factor in if you wanted to use this. And then SEMA 3 is a new one, and this is the one we're using right now with the study led by Dr. Rebecca Summy at the University of Alabama. And it's called SEMA 3, and this one's free. And so this is another great option to use. It operates very similar to Paco. They all operate the same way, where they employ the experience sampling method. So they allow you to program small surveys and send pings throughout the day with whoever you're partnering with. And so just quickly, I'll tell you a little bit about some of the results from our studies. This is where it gets a little speechy, so I'll kind of just gloss over it. But in this study, we had data from 772 therapy sessions. So we had 106 SLPs, and each one can provide us with up to 15 data on up to 15 sessions per week if they are seeing a kid within 30 minutes of having received that ping on their phone, right? So not every single time they got a ping did they either respond or they maybe said no, that they weren't seeing it. But we have documentation from 772 therapy sessions. And so what we did here with this study is we wanted to look at the different treatment approaches. So you can swap that out for evidence-based practices. So the evidence-based practices that they are using in the schools to provide services for kids who have speech sound disorders. And so we developed a coding scheme to code the different evidence-based practices or treatment approaches that they said they were using. We developed a list of 31 possibilities. 24 of that 31 reflected pre-established evidence-based interventions. And then we added in 7 additional codes, because as we went through the information that SLPs were telling us, not totally surprising, but we did find that there were things that SLPs were saying, this is the treatment approach I was using. And we were like, that's not a treatment approach. So we wanted to have some way to code that and represent that. So it was things like they would say, we used a mirror, right? You can use a mirror in speech therapy regardless of what evidence-based practice you're using or what treatment approach you're using, right? It's just like having the kid watch their own mouth when they're producing a speech sound. That's not a treatment approach. It's just a therapy tool. So that's just an example. So we had to figure out a way to kind of code those. So we developed 7 additional codes to reflect that information. And then this is the top 10 list of codes from our data. Anything listed in parentheses is not a treatment approach. So you'll see of the top 10 things we were finding in our data across almost 800 therapy sessions, the majority of what SLPs are reporting that they're doing are not things that are considered evidence-based practices. Now, it doesn't necessarily mean that they're never using an evidence-based practice. It also might reflect more concerning issues with respect to their inability to name the approach they're using. So maybe they are using an evidence-based practice, they just don't know what it's called or don't have a name for it. And so as someone who teaches that graduate course here at FSU, I think that that also reflects a little bit more on some graduate education or professional development needs of these clinicians as well. This was another same data set, another publication from that same data set where we were looking at this idea of group size that I mentioned. So I'm very interested in whether or not group therapy is effective for kids just in general in schools. And what we found is when we asked SLPs to also tell us the dosage of the session, so meaning how many trials they provided the child to practice their speech in the session, for every child that they added to their therapy group, the dosage of that session went down by 13 trials. So for context, on average, we anticipate that the dosage for one child in one session should be 100 times. 100 times they get to practice their speech sound in every session is the recommended dosage. So for every kid that's added to a group therapy session, that dosage goes down by 13 trials. So you can imagine how many kids you're adding to a group is going to continue to water down the effectiveness of that treatment. Even if it is a high quality evidence-based practice, you simply can't achieve the dosage that's needed to see quicker outcomes if you're adding more kids to the group. And so we did find a disconnect in our data because in a 2020 study that was not an experience sampling method study, this was actually data from Laura Justice's lab at Ohio State. We found that children who received group-based services as reported by their SLP increased their speech skills more so than children who received individual services. Now, in that study, again, this was not experience sampling. We had no data on dosage, so we don't know what the dosage of the session was. And we had no data on the therapy approach. And that's because it was not the design of that study. It was not the purpose of that study. So that was one of our first kind of forays into this work. So then the follow-up study, which is the experience sampling one, the second one, again, we found the dosage decrease when we add kids to the group. Now, this analysis did not include the therapy approach, even though we do have that information. This is just looking at 1 week of their work. It's not looking at an entire school year. Like the first one looked at an entire school year. And then a big problem with this second one, the experience sampling, we're asking the SLPs to tell us what they're doing in the therapy session. We have no interaction with the kids. So we never saw the kids. We never talked to the kids. We didn't consent the kids to participate. We got no information identifiable in any way about the kid. So we actually had no speech data. So we know that dosage went down by what SLPs are reporting, but we have no idea if it had any impact on the child's outcomes because we didn't measure any child outcomes. So that led to our need to do a bigger study, which is what we're currently doing now in an NIH-funded study. Or in this kind of consideration of feasibility stage of pre-implementation. So we're now collecting exploratory data from our NIH R01. It's called APPLES, and this is Academic Progress in Phonological Learning for Elementary Students with Speech Sound Disorders. And it is split between me here at Florida State and my colleague, Dr. Katie Cabbage at Washington State University. This is what we looked like when we were young, fresh-faced doc students and had this idea, and here's what we look like now. And so this study is in its second year. These are our wonderful project managers who literally make the world go round. And we have an advisory panel of SLPs. So now we're really trying to kind of bridge this gap between our two, kind of that disconnect that I identified of like, okay, so this is saying that some kids are getting better, but we don't know why because we know nothing about the dynamics of the session. And then when we ask about the dynamics of the session, we have more information, but we didn't have the kids. So we're kind of pulling all of that together in this study. We have an advisory panel of school-based SLPs. We have one in Florida, one in Washington, because those are the states that we're collecting data in. And then we have one in Pennsylvania who is kind of serving as to have a state that we're not actually collecting data in, but can provide a little bit more guidance on. Essentially, they help us determine, if what we're asking our partnering SLPs to do is too much. So they provide a lot of really good support to make sure that what we're asking is not too much in this study. And so the way that this study is designed, we have 4 non-overlapping cohorts. So every school year, we recruit 20 SLPs and 100 kids, a new group every academic year. And so for each site, which is here at Florida State, and then Washington State, which is where Katie is, we get 10 SLPs and 50 kids per site. And so we are about to start data collection for the second time point of year 2. And so we have 40 SLPs and almost 200 kids already. And so this is just in general the structure of this study. We are currently recruiting SLPs for year 3, and which will be this next academic year, 26-27. We test all the kids. So we have we recruit the 10 SLPs per site. Then the SLPs help us recruit kids. So they recruit kids from their caseload up to 5 who have speech sound disorders. We go into those schools and test all the kids directly. So we're getting all this data directly from the kids. Each kid goes through a 3-hour battery of testing in the fall and then again in the spring. Over the course of the entire academic year, instead of just one work week, the SLPs are logging all of their therapy for all of those 5 kids. So every session, how many minutes it is, what's the dosage, what's the therapy approach, how many kids were in the group, where did it take place? Because as a former school-based SLP, I did a lot of hallway and stairwell therapy. And so we kind of want to know where this is happening. Stairwells are not acoustically sound for speech therapy, right? And so we want to kind of understand that a little bit too. And then, yes, that's the majority. The SLPs also record therapy sessions. So they record 3 therapy sessions per kid per year. So we get 15 videos per academic year, 1 in October per kid, 1 in January, 1 in April. And then we go back in the spring, test all the kids again. So we have a pretty rich data set already where we have beginning of the year information, end of the year information, and then we'll also be able to look at if the growth that we see in their phonological skills and in their speech ability, how it's related to the kind of therapy that they're receiving, if it is. And so I think I've already said this, the therapy data that they report on, and then the SLPs also complete a demographic questionnaire. So we have a lot of background information about each SLP. I mentioned the therapy videos. Also, the families fill out a questionnaire. The families of each child fill out, birth, development, education information. And then this is in general our logic model for what we're looking at with how we're kind of conceptualizing the idea of phonological knowledge. We also collect descriptive data. So we do a hearing screening for every child. We look at their language abilities, oral language abilities. We measure their nonverbal IQ. But our main constructs of interest are their phonological knowledge. And so we're looking at speech production or speech perception, phonological working memory, phonological awareness, word decoding, that's real word and non-word decoding, spelling, and then of course, speech sound production. And so these are our main constructs of interest. And so I thought it would be fun to show you. This was one of my super nerd out moments that I even called my mom and was like, get on Zoom, I have to show you this really cool thing. So whenever we wrote this grant, we had hypothesized, which by the way, for the doc students in the room, this grant was funded after 6 submissions across 8 years. So I was very, very, very excited to finally get it. And so in one of the revisions, we had said we were going to do a latent profile analysis to kind of look at phonological skills. And I had hypothesized that there would probably be 4 profiles, but maybe there'd be 3 and maybe there'd be 5, but I was kind of suspecting there would be 4. And one of the reviewers was like, I'm not sure what you mean by latent profile analysis. Why would there be 4? Can you provide a little bit more information? So I was like, sure, here's my pretend data. So this is an actual graphic that was in the grant of I just put some pretend Z-scores in Excel and had it, make these 4 profiles of what I hypothesized we would see. And then our wonderful methodologist, Dr. Schatzsnyder, ran our data for the ASHA convention in November. This is just year 1 data, so we still have a lot more kids to test, but there are in fact 4 profiles. And it looks, I'll go back and forth, it does look somewhat similar to what we hypothesized. So we kind of hypothesized everybody would have, the variables are in the different order, by the way, so I apologize for that. But we hypothesized that their speech production would be low for everybody, and that there would be variability seen across speech perception, working memory, that there'd be some kids who have poor speech production, but everything else is fine. Their phonological awareness is fine, word reading is fine, and it really is more of a motoric issue related to speech. And then there would be some kids that have really poor speech production, but also their ability to use phonology for everything else, reading and spelling, is also really poor. And that is essentially what we found. The percentage of consonants correct here, this is speech production. So how many consonants they had correct on this measure, which is the Goldman-Bristow test of articulation. And so you do see that there's 4 profiles here of kids. This is not really about partnering with SLPs anymore, but I couldn't not show this because it's just so cool. And so this is year 1, time point 1 data. So again, we have 2 time points every academic year. So this is just the first round of kids. So I think this is 67 kids. And so we'll continue to build this up because we'll eventually want to create our latent profile analysis, including all the kids that we end up testing. But stay tuned for more information on that. But I will just kind of wrap up by saying that our partnerships with SLPs made this possible. The SLPs have just been absolutely incredible to work with, that have partnered with us on Apples. They are just an incredible resource for us. We're learning so much from them. And I hope that they're learning something from us, but we've really enjoyed getting to partner with them and to try to help all of us understand this population of kids a little bit better. I think the conversations that we've had in developing this partnership and being able to collect data together has been really helpful in trying to understand what some best practices might look like in the schools. I'm really excited to start to dig into the therapy data that the SLPs have sent. We're really only just getting to that now as far as data cleaning and processing. But I'm really excited to see, for these kids in different profiles, is the type of therapy or frequency of therapy that they received related at all to which profile they end up in? And then this is just fall, so does that change in the spring? Do the number of profiles change in the spring? Does profile membership change in the spring? And how does that relate to the receipt of services? So if they're using evidence-based practices, or I think importantly, even if they're not reporting using evidence-based practices, they're doing something that's effective, right? And so what can we learn from them that's happening in the schools, which is why the therapy videos are so important too, because we'll be able to look and see, this SLP is not reporting that they're using a therapy approach that's documented in the literature, but they're doing something. These kids are improving. And so maybe, we need to kind of tap into that and figure out what they're doing and why it's so effective. So, I'll stop there. Thank you for your attention and time and letting me nerd out on methodology and implementation science and speechy stuff, but I'm happy to answer any questions you might have. Yeah, you have a question?
No.
Okay.
Just a process question, which is, it struck me, which I think is very, like a very realistic type of thing when you're applying to external grants.
Yeah.
That you said 6 or 8 submissions.
6 submissions over 8 years.
Over 8 years,
Mhm.
okay. And how, can you, it doesn't have anything to do with your research, but how did you emotionally keep going?
Not well. No, not well. Was that, yeah, there were some low moments, but I will tell you, I think, there was never a moment where, when we got feedback from reviewers, there was never a moment where I was like, they hate this. They think this is a terrible idea. We were always getting relatively positive feedback. One thing I should disclose too is that my previous institution, I was at Emerson College in Boston before, as a faculty member before I came here, and that's a very small school, and they're eligible for the R15 mechanism through NIH, which is for very small institutions. And so that was the first 2 submissions were as an R15. And the reviewer feedback was like, cool study, but not feasible with the amount of resources that you say you have. And so it was, and I'm actually very grateful for that, because they were right. There was not resources there to do the kind of, now that I've really been in it and have been doing it, they were right that I really did not know what I didn't know, which was that I didn't have the infrastructure to do research, which is in part why I'm here and not there. So that was part of it. But I will say, we had, I have really good collaborators, so that helps so much. And then, because I was able to do some smaller shoestring level budgetary studies, like some of the surveys, that really helped to sustain me in terms of, not everything is about getting a publication, except when you're pre-tenure, everything's about getting a publication. And so that really did help me to be able to sustain a track record of publication that I was doing this work. And I think that helped emotionally, but it was definitely hard to have that kind of repeated rejection, but it did teach me a lot. And I think it made the project a lot stronger. So yeah.
What was the tipping point? Why do you think it was more finally? What changed that made the reviewers resonate?
That's a good question. Well, actually, I think one of the biggest changes in would have been this 5th submission. So the 3rd new submission or 5th submission, was the inclusion of implementation science frameworks. Okay. That it felt a little less like, we just want to know what SLPs are doing, and this is exploratory. And more like, we have a structure here. We're going to follow these stages of implementation, and this is a system and we're going to follow this. And this is more of a, even though it always felt that way in my head, that gave me the framework to really, or the language to really be able to explain it in a way that felt a little bit more scientifically sound, as opposed to, I just want to get in the schools and see what they're doing and figure it out and help them and help these kids. It really provided the framework. I think that is probably.
Is that a reviewer feedback comment, or did you all decide to do that?
No, it was not a reviewer
Okay.
feedback comment. Yeah. Yeah. Mhm.
We have a question in the chat.
Oh, okay. Sorry.
Could you elaborate on the resources you used to develop the family questionnaire?
Oh, sure. So we, as far as the resources used to develop it, so we asked the families, we administer it through RedCap, which is another survey-based system and database system that FSU has access to. And so we asked the families to tell us, we get kind of the general information, their demographics. So we get a lot of the child development information from that, child's date of birth, family socioeconomic status, maternal and paternal education levels. And then we ask a lot about like first words, if the parents have any concerns about speech or language and when those occurred, if they have any concerns about hearing or reading and when those occurred. We ask about if they have a history of ear infections, and if so, did they receive pressure equalizing tubes? Or not. We ask about, we do have some questions where we ask about the home literacy environment too. And so that has, I'm not gonna be able to think of the citation off the top of my head, but that does come from other research studies I can send along to Lindsay to share. It's a smaller version, abbreviated version of a home literacy questionnaire where we ask like, do you have a library card? Do you read at home? Do you enjoy reading at home? If you have a spouse, do they read for pleasure? Do you have a newspaper subscription? Just kind of asking about what the home literacy environment is like. I think that's mostly what we ask, but I'm happy to expand more if there's more specific questions.
Thank you.
Mhm.
Kelly, what was the funding mechanism? Was it NIH?
Mhm.
Which NIH?
NIDCD,
Okay, and R,
R01.
it was an R one.
Mhm. Yeah.
That's huge. Congratulations. That's perseverance.
It is perseverance. Yeah. Mhm.
Well, also the idea from an inception when you were a doctor, I love
Yeah.
that slide because
Yeah, let's see.
some of the ideas that you had early on, I feel like we were talking about some pro summers, some of the ideas that you guys might be having right now.
Yeah.
Could come into fruition. You can
Yeah.
do it. If you could think it, you can do it.
And the reality is like this is not even exaggeration. Katie and I were PhD students together at the University of Nebraska Lincoln, and both had come there from our jobs as school-based SLPs, and both interested in kids with speech sound disorders and the overlap with dyslexia and literacy. Literally had conversations about the exact study we're doing now at that time. And so it really let's go to reality here. It's really special to be able to get to do that with someone that you had this close partnership with. That helps a lot. Emotionally, that also helped a lot during the times that we didn't get it. Was just like, that's okay, we're gonna try again. And I always tell my doctoral students, anytime there's, if you get a bad review or a rejection or something, like you're allowed to be sad. I think there's a lot of like toxic positivity in academia. It's like, just get back on your horse. No, you're allowed to, like, it's a lot of work. You're allowed to be sad, like not forever, but like give yourself a day or a week to be sad and cry and throw things. Write a response that will not see the light of day, right? And then you do have to try again, because this work is hard to do, and funding is increasingly harder to get. So it does that perseverance is part of it, but it is very special to be able to work with someone that on a project that both of us really have thought about for a very long time.
So, thank you for your talk, I really enjoyed it. And I was making sense of it through a very different lens, which is like undergraduate STEM education and active learning approaches. But
Yeah.
this notion of like, and then there, in K-12, you have all this implementation research. And so I'm thinking of some of the things around one-on-one versus one-on-many, and also like conceptualization of implementers. So I think I'm gonna go with my conceptualization of implementers. I feel like there is there's definitely some research that sort of views teachers as like, we figured out what works, and their job is to do it the way we said. And
Yeah.
if they don't, there's something wrong with them.
Yeah.
Versus like you talked about people like oh, well, they're giving therapy in a stairwell because that's the space they have to, you know what I
Yeah.
mean? Like that you're adjusting to your context in ways that are sensible. So I'm curious, like, what is your thought in terms of like how are the implementers conceptualized in the framework, and then how does that show up in your data?
Yeah, that's a great question. I'm really interested to see what we do end up finding with that too, because I think another thing that's important about this is I think like in one of our ESM studies where we found that SLPs, and I realized too that I think my the way I delivered that data point is in more negative tone, but the reality is the fact that they weren't able to name a specific treatment approach was way more informative to us than anything. The fact that they're probably doing something that is evidence-based and they maybe just don't have a name for it, or they have heard that mentality that you're describing, which is this is the exact thing we've studied that we've found to be effective, but you have to do it this exact way or else there's something wrong with you. I think then a lot of SLPs are like, okay, well, this has never been studied in groups of kids and I can only see kids in groups, so I'm just not going to do that, you know? And so I feel like there's like an aversion to using a new approach because it's like, well, will it work with all of these kids at once? And we don't know that, but the irony for me too is like what they are doing has also never been tested in groups. So it's, you know, the argument is it doesn't really work that way. But I think too, what we'll find, because we're also collecting data from the SLPs in the SLPs questionnaire, we have them fill out information about their job satisfaction and self-efficacy. And so I'm very curious to see how those kinds of factors contribute to maybe the types of therapy approaches they report using, the evidence-based practices they report using, whether or not they ever report using an evidence-based practice, and then kind of the outcomes that we see for their kids. Because I think there are some SLP level factors or teacher level factors that actually contribute to SLP's feelings of, you know, I can do that. I can learn how to do something new, you know, especially when you've been practicing for 10, 12, 15, 20 years, you hear about a new treatment approach. Are you going to try it? Or are you going to be like, no, this is what works for my kids and I'm just going to always do it this way. So I think that the individual implementer is going to be a huge part of what we see as an active ingredient to kids' success. But I'll be really curious to see if we also find that like some of the information they provide to us about like their self-efficacy, if that is a driving factor, you know, self-efficacy kind of being that like your internal belief that you can do something, right? And so do the SLPs who have higher self-efficacy choose to do a variety of different evidence-based practices because they feel like, oh, I can try a bunch of different things with these kids, and if it doesn't work, I'll try something else. And you know, is that kind of the driving factor? So I think as far as like the individual implementer, we will be able to look at how maybe some of their individual factors may contribute to child outcomes. I don't know if that exactly answers your question, but I think that those are things that you could also measure at the teacher level too, you know, to see if that's related to why they choose to do something in a particular way.
A question about the app. Did you collect any feeling data? That's not the right word for it, but like the pings. Did you get any sense from how they felt about getting pinged multiple times and how that influenced like, I'm not responding to you right now because I'm tired of hearing your ping, or oh, this is something that I need to do. I'm just curious.
Yeah, that's a great question. We did not do any social validity of it. But that would be a great way. We should have followed up with something related to that. I love that idea. But no, we did not do that. Now, what I will say is we didn't necessarily see any fall off where SLPs were participating Monday, Tuesday, and then by Friday they were like, absolutely not.
Okay.
So we didn't really see that. If they were low responders, they were kind of low responders across the board, which basically meant that, you know, if they got the ping and the question is, did you see a kid within the past 30 minutes? They only have 60 minutes to respond to that, which also maybe they just didn't have their phone on them or, you know, didn't see it in time and it expired. So that could happen. The other thing we did hear from some SLPs, only because it did affect their ability to participate, was that their school didn't have good service. And so they couldn't get they would maybe get like 3 pings at once and they'd be like, oh my God, you know?
Right.
So we did get that feedback only because they were like, I'm not sure if this is,
Interesting.
you know,
Sure.
gonna work for me because I don't think my cell phone service isn't great here. We heard that in the moment, but I would love to know if it felt, I mean, actually Rebecca is doing a version of this right now. We could potentially tack on.
Yeah.
Rebecca Semi.
Uh-huh,
Yeah.
yeah.
I'm just curious, because I mean.
Yeah,
We're
I love
using
that
an app
idea.
now to communicate with caregivers, and I'm wondering if what the response would be.
Yeah.
from Getting. Like.
Yeah.
Moment collect, like, how would you feel about that as a parent? Like,
Right.
would it drive you absolutely insane, like,
Right.
never respond.
Yeah,
Or
well, and
would it
I,
help to remind you that, oh yeah, this is something I need to check myself on. Or
right,
everything.
well, and I think too, you know, we, all of those studies, you know, they're self-selecting to participate,
Sure.
and so they're choosing to participate. We told, you know, it's only 5 days, it's only the week, but of course, like, I get basically no alerts on my phone. Like, I'll go into my email and see if there's email, but I do not want my phone telling me when there's an email, you know, so I don't like pings. I don't,
Sure.
so the
Yeah.
irony of that is not lost on me either, but yeah, I think that's a great question. It could be a great follow-up. Yeah, thank you.
The experience sampling method, how did you decide on the, having to respond within an hour? Is that the ideal?
Yeah, that is the ideal structure of that. Again, because you're trying to curtail this issue of memory erosion, you know, with the idea being like, you know, if you're seeing 10 groups of kids in a day, will you remember how many kids were in that group in an hour? You know? And so that's part of it. And I think most of the ESM studies that I've read, there have been other ESM studies in my field, communication disorders. It is mostly a similar structure where they have, you know, the question is, did you do this within the past 30 minutes? And then they have 60 minutes to respond to that. What's also been interesting, and I don't know if this would be of interest to anyone here, but a lot of the other ESM studies in communication disorders are about people with communication disorders. And so who you're pinging is not the interventionist, but the client or the patient. And so it's people who stutter. And so there's a lot of emotional baggage that is associated with stuttering. And so a lot of some of that research has been asking someone, like, in the past 30 minutes, did you have a major disfluent moment and how did you feel about it? And so it's more about like the emotional connection to it. Or adults with aphasia, adolescents with cochlear implants. Those have been some of the populations that have been studied. I think you could do something really cool with caregivers too.
Thinking about it, because, you know.
Yeah.
I know where you.
Yeah, you do.
Yeah.
So did you find that the payment was effective? Why do you choose a payment versus maybe do they get a report of what they submitted that would help them in another way? I know the payment is probably the most effective according to other research that shows if you just pay people to do stuff, they'll do it.
Yeah.
But so can you talk about that?
Yeah, that's a great question. We did not provide them with a report of their data, but I really like that idea to see, just, you know, kind of have it condensed into like an aggregate version of what they reported. So that could be something we do in the future. It tends to be customary in the literature on ESM to do this similar payment structure. I've seen, you know, $1, $5, $7. I haven't seen much more than $7 because you're paying them per ping. Most of like ours is a very kind of customary design where it's 3 times a day, 5 days a week. Some will be, you know, maybe 2 weeks and maybe it's twice a day. Some are maybe more in a day and it's only 3 days. So I think you know, you can kind of just decide what your budget can handle there. But I did wonder too how much the payment kind of factored into it. The other thing I did not mention about this ESM study was they also completed a one-time demographic survey where they gave us information about their years of experience and caseload size, and if they took a graduate class on treating speech sound disorders and what was included in that class, and a bunch of other kinds of things, and job satisfaction, self-efficacy. That's kind of like our standard survey structure. They got $20 for completing that. And just, you know, if they completed it, they got $20. And then they got on top of that up to $45 for completing the week. So I think Yeah, I think the payment did probably contribute. I will also say, like, we had a really structured plan around communicating with the SLPs so that we weren't getting people who were just taking a survey to get $20, meaning non-SLPs, because we've gotten in other surveys, we've gotten like really bad bot infections and really bad situations. So they would have to reach out to us via email to start the process. So it wasn't just a link that we posted online. They had to email us first, and then we would kind of say, okay, here's what this looks like. Here's the plan. You do this first, then email us back. And we were looking for them to, with Paco, with the app that's no longer functional, they had to have a Gmail account. And so that's not a factor for the other apps, thankfully, but so they had to, like, there was a lot of back and forth with making sure that they were eligible to participate and willing to participate, but I think the payment certainly helped. Yeah, I don't know if that really answered your question.
It
but
does, no, because we've been playing around with how much do you pay somebody to do a survey,
Yeah.
things like that, and how many surveys responses do you get?
Yeah.
Using like the Amazon, what is it called?
Insert.
Oh, yeah.
Mechanical survey.
Yeah, mechanical turk.
They-
Yeah.
And so we were paying too little.
And did not get.
It did not.
Yeah, no, I mean, that makes sense. And I think that mechanical turk's a great option if you don't need a particular like clinically trained population of people or something like that. You have a lot, there's so many options there. I've looked into that too. Yeah. It's tricky to know how much to pay. You know, it is tricky, and it, you know, your budget drives that a bit, which is basically what happened here. Was like our power analysis, you know, was basically we needed 180 SLPs to answer our question. So we're like, okay, well, here's how much money we have, so we'll do this much money per SLP. You know, it was not super scientific and more just like what's available here funding wise. But I don't know that there's necessarily a right or wrong way, but I will say the $3 per response is mostly what I've seen in the literature. Any other questions? Thank you all for coming, you guys. Hey.
Colloquium for the spring semester due to scheduling snafus and other things with March and April and it, so anyway, we appreciate those of you that have been coming and participating. It really helps a lot to keep the interest going. So look out for information for next academic year.